Hey everyone, this is the pre-class PowerPoint on fluid, electrolyte, and acid-base balance. Actually, I guess we're going to talk about fluid, electrolyte, and acid-base imbalances. Ha! Anyhow, the interesting thing about fluid, electrolyte, and acid-base imbalances is they really aren't diseases in and of themselves. They're more problems that can go along with a bunch of different diseases. It's kind of like fever, fever isn't a disease all by itself, but it's more of a symptom of a disease. And it can go along with a lot of different diseases. But just because fluid, electrolyte, and acid-base imbalances aren't diseases in and of themselves, that doesn't mean that they can't be really serious problems. In fact, your book says that fluid, electrolyte, and acid-base imbalances can be incompatible with life. Okay, meaning they can kill you. So it is important that we be able to identify and know how to correct all these imbalances. Now, fluid, electrolyte, and acid-base problems are all sort of interrelated, but in order that we don't get ourselves all mixed up trying to talk about them all at one time, we're going to talk about each of them separately. And we're going to start with fluid balance, because this is probably the one that's most familiar to most of you. Probably the first thing we need to do is review a little bit about the idea of fluid compartments. You remember there are two main fluid compartments in the body. There's the intracellular fluid and there's the extracellular fluid. Intracellular fluid is all the fluid that's inside all of the billions of cells that we have in our bodies. And actually about 2/3 of all your body water is intracellular. Extracellular is all the fluid that is outside the cells. And we subdivide extracellular fluid into 4 different sections. Okay, we have intravascular fluid, which is the fluid that's inside the blood vessels. We have interstitial fluid, which is the fluid in between cells. We have the lymph, which is the fluid in your lymph vessels. And then we have what we call transcellular fluid, which includes things like your cerebrospinal fluid, the fluid in all the different body spaces you have. Like you see in this picture, you can see some of the places in your body where you have this transcellular fluid. All these body spaces like your peritoneal space, your pleural space, the pericardial space, your joint spaces. There's fluid inside your GI tract with all the digestive juices. All of these things are considered transcellular fluid. Now, normally, there's only a small amount of transcellular fluid in all of these compartments. But sometimes the fluid in these body spaces can get abnormally large. Like we talked about one example not too long ago where we talked about if you get way too much fluid in the pericardial space. Remember we call that a pericardial effusion. So sometimes some of these body spaces can develop an abnormally large amount of fluid. And if that happens, we call it third spacing. Now, fluid can move back and forth between these different compartments. It can move from inside the cell to the interstitial space. It can move from the interstitial space into the blood, and it can go back again. And as the fluid moves back and forth between the different compartments, it carries with it gases like oxygen or carbon dioxide, nutrients, waste products, and so forth. Now, if we're talking about the movement of fluid between the cells and the interstitial space, or the spaces in between the cells, that movement usually occurs by osmosis. And you remember osmosis is a form of passive movement that is determined or regulated by the osmolality or the tonicity, or to put it in an easier way, the concentration of the interstitial fluid. So depending on whether the interstitial fluid is hypertonic, hypotonic, or isotonic to the fluid inside the cell, that's what's going to determine which direction the fluid is going to move. So you remember what hypertonic, hypotonic, and isotonic mean, right? Okay. whether it's more concentrated, less concentrated, or the same concentration as the fluid that's inside the cell. So if you look at this slide, you can see what the effect is going to be on the cell if it's surrounded by interstitial fluid that is either hypertonic or hypotonic or isotonic as compared to the fluid that's inside the cell. Okay, if you have a cell that's surrounded by interstitial fluid that's hypertonic or more concentrated than what's inside the cell, which way is water going to move? Right, water's going to move out of the cell. And when water moves out of the cell, what happens to the cell? It shrinks. Okay, on the other hand, if you have a cell that's surrounded by interstitial fluid that is hypotonic or less concentrated than what's inside the cell, now which way is water going to move? It's going to move into the cell, and when the water moves into the cell, what happens to the cell? It swells. Okay? Now, if the cell is surrounded by interstitial fluid that's isotonic, or it's the same concentration as the fluid that's inside the cell, what's going to happen is the cell does not shrink, it does not swell, it stays the same size. You might have water that moves into or out of the cell, but they're going to move in equal amounts, so the cell will not change size. Okay, so that's basically what controls the movement of water between the cells and the interstitial space. It depends on the concentration of the interstitial fluid. Now, what if instead of looking at what causes fluid to move between the cells and the interstitial space, what if we're interested in what causes fluid to move between the interstitial space and the intravascular space, or between the tissues and the capillaries? Now we have to look at some different kinds of forces. Each of these two compartments, the tissues and the capillaries, both have a hydrostatic pressure that's trying to push fluid out of the compartment, and they have a colloidal osmotic pressure that's trying to pull fluid into the compartment. Now, the hydrostatic pressures are more of a mechanical force, and it's due to the volume of fluid that's present in that compartment. The more fluid you have in a compartment, the higher the hydrostatic pressure, and the more it's going to try and force fluid out of that compartment. The osmotic pressures are due to the presence of proteins in the fluid of that compartment. Because the proteins draw the fluid in. That's why we call it osmotic drawing power. And we're calling this a colloidal osmotic pressure because colloidal refers to protein. And in this instance, it's the proteins in the fluid of the compartment that are providing the osmotic drawing power, and not things like electrolytes and so forth. So like we said earlier, each of these two compartments has a hydrostatic pressure that's pushing fluid out and a colloidal osmotic pressure that's pulling fluid in. So the capillary hydrostatic pressure, or in the slide it says capillary filtration pressure, but it's the same thing. Okay, so the capillary hydrostatic pressure is trying to push fluid out of the capillary into the tissues, while the capillary osmotic pressure is trying to pull fluid back in. And remember, the thing that gives fluid its osmotic drawing power is proteins. And you know, you have a lot of plasma proteins in your blood, like albumin, to give your blood osmotic drawing power. And those plasma proteins are usually too big to get out of the vessel, to leave the vessel. So the plasma proteins stay inside the capillaries and they pull fluid in. The tissues also have a hydrostatic pressure that is trying to push fluid out of the tissues into the capillaries. And the tissues also have a colloidal osmotic pressure that's trying to pull fluid into the tissues. You know, there are some proteins in the tissues as well, and so those proteins in the tissues give the tissue compartment its osmotic drawing power. So you see that these four pressures are always interacting with each other. Some of the forces work together, Some of them are opposing each other, but they're always interacting all the time. And under most circumstances, the end result of the interaction of these four forces is such that there's a small amount of extra fluid that gets left in the tissues. And that small amount of extra fluid usually gets picked up by the lymph system and then returned to the general circulation through that route. So that's what normally happens. But if you change any one of those four forces, now you might see a different picture. For example, let's say something happens to change the capillary colloidal osmotic pressure. Like maybe you have a patient who is very malnourished, is not getting enough protein, so can't make the plasma proteins like albumin to give the blood its osmotic drawing power. What do you think is going to happen? Where is all the fluid going to end up? Okay, if you decrease capillary osmotic pressure, now we don't have that protein pulling the fluid in, so extra fluid is going to end up in the tissues. And when you get a whole bunch of fluid ending up in the tissues, what do we call that? Right, we call it edema. Have you ever seen pictures like this of the little poor starving children who aren't getting enough calories and not getting enough protein, and they have these big swollen bellies? Okay, the reason for that is if they're not getting enough protein, then they can't make albumin, and so their blood does not have that colloidal osmotic drawing power. Since it doesn't have that osmotic drawing power, the fluid leaks out of the blood vessels into the tissues, and you get these little starving people with big swollen bellies. What about if we change the capillary hydrostatic pressure instead? What if, say, for instance, somebody got a big clot in one of their leg veins? Okay, so now the blood in the leg can't get back to the heart. It starts to pool in the blood vessel, and capillary hydrostatic pressure goes up. In that situation, which way is fluid going to move? Okay, if the hydrostatic pressure increases, it's going to push the fluid out of the capillaries into the tissues, and again, we're going to get edema. You would see something like this, where all that extra hydrostatic pressure in the capillaries pushed the fluid out into the tissues, and so now you have a lot of swelling. What about the swelling and edema you see in inflammation? You remember one of the cardinal signs of inflammation is edema, right? So here's how that happens. You remember that we said part of the inflammatory response involves an increase in capillary permeability, right? In other words, the capillaries get more leaky. Well, it's not just fluid that's leaking out of those capillaries, but it's also some of the plasma proteins. Because of that increased capillary permeability, some of the plasma proteins are able to leak into the tissues, and now the tissue colloidal osmotic pressure is going to increase, right? So now the tissues have more osmotic drawing power, and so it's going to pull more fluid into the tissues, and now you have edema, right? So you might have someone with inflammation in their finger, and their finger will end up looking like this, with lots of edema. Now, remember we said that usually when these four forces interact, the end result is a small amount of extra fluid in the interstitial space, and that gets picked up by the lymph vessels and returned to the general circulation. What if you had a patient who had some of their lymph vessels removed? Common example, you've heard of women who have breast cancer and they have these radical mastectomies to treat it. Well, one of the things that we do in a radical mastectomy is we remove some of the lymph vessels in the axillary region on that side, because we're thinking that maybe the cancer spread to the lymph nodes and that kind of thing. But if you remove lymph vessels, what have you just done? Okay, you've kind of taken away the route for the extra fluid in the interstitial space to get back to the general circulation. So you might see women who've had radical mastectomies have trouble with edema in the arm on that side of their body. Here's an example of a woman who had a radical mastectomy on her left breast. And the problem that she's having there is called lymphedema, because we can't get that extra fluid back to the circulation through the lymph system. This is the reason why, if you've ever worked with a woman who's had a radical mastectomy, usually there's a sign at the head of the bed that says, don't do blood pressures, don't do venipuncture, don't start IVs on that arm. Because if we cause trauma to that arm and there's inflammation and swelling that develop, we really don't have a way to get rid of that swelling, because the lymph vessels are gone and we can't get rid of, we have a very, very difficult time getting rid of that edema. Okay, so hopefully by now you've gotten the idea that when we're talking about fluid disorders, we may not necessarily just be talking about the amount of fluid in the body, but we might also be talking about problems with where that fluid is located. Okay, what are the main functions of fluid in the body? Well, basically there are two. Obviously, the first function is to maintain your blood volume, to maintain your intravascular volume. So in that respect, the fluid serves all the same purposes as your blood does. The other big job of fluid in the body is to just help provide the optimum environment for metabolism and other cell functions to take place. Remember, we said that all the enzymes inside your cell need to do their thing so that we can keep the cell alive. Okay? In most cases, all of those chemical reactions that are required to do that take place much more readily in a fluid environment. So that's the other purpose of the fluid in your body. Now, for all of our fluid and electrolyte topics, we're not going to talk about the normal sources of gain and loss. Okay, like in this slide, it shows how does water get into the body, how does water get out of the body. We could talk about that for sodium and potassium and calcium as well. But all of that is there in your study guide. We don't really have time to talk through all of those things separately. Those should be a review to you. So instead of going over it, I'm going to let you look over your study guide. Make sure you understand those things. If you have questions, bring them to me in class or go ahead and text me. The other thing that we're not going to look at in class, risk factors for the different kinds of imbalances. This slide shows the risk factors for fluid volume deficit. Okay. All of those risk factors for the different fluid, electrolyte, and acid-base imbalances that we're going to talk about are in your study guide. But again, we don't have time to talk about all of the risk factors for every different imbalance. So I'm going to let you look at the risk factors on your own as well. And if you have questions, please feel free to contact me. But the point I want to make is, even though we're not going to specifically go through the normal sources of gain and loss or the risk factors for every imbalance, I want you to notice that those two pieces of information are not two totally separate things that are not related to each other, but they are very closely related, right? Think about this. If you know that one of the normal ways that water gets into the body is you drink it, okay, and then you see that the patient can't drink because they're vomiting or something like that, then that should be a good clue that vomiting is a risk factor for a fluid imbalance, right? If you know one of the normal ways that water gets out of the body is in the urine, and then you see that the patient has kidney failure and is not making urine, okay, well, that should be a big clue that kidney failure is a risk factor for a fluid imbalance. So you see how they're related to each other like that. Okay, so when you look at your study guide and you're looking at the normal sources of gain and loss and you're looking at the risk factors, I want you to think about it like that and see if it makes sense to you. And again, if something doesn't make sense to you, make sure you bring the question to me. because I am going to hold you responsible for that information on the test. Okay, not from the standpoint of like I'm going to say, so name the 4 ways that water gets out of the body or anything like that, but more from the standpoint of if I were to give you a patient scenario and tell you this patient has hyperkalemia, would you be able to look at that scenario and make a good educated guess as to why that patient developed that imbalance? Okay, so I want it to be from a more practical standpoint. So look at the sources of gain and loss, look at the risk factors for the different imbalances, and see if you can make the connections. And again, if you need help, feel free to contact me.
Okay, we're going to look at 2 common alterations in fluid balance, isotonic fluid volume deficit and isotonic fluid volume excess. Okay, let's start with the deficit. Deficit means there's not enough, right? So isotonic fluid volume deficit means that there is not enough or a lower than normal amount of fluid present, which is why we sometimes also refer to it as volume contraction or volume depletion. Now, your book defines isotonic fluid volume deficit as an isotonic decrease in the extracellular fluid compartment. Okay, so there are 2 things about that definition that I want you to notice. First of all, we're talking about the fluid in the extracellular compartment. Okay, so we're not talking about the fluid inside the cells. We're talking about the amount of fluid in the extracellular compartment. Okay, the other thing I want you to notice about that definition is that we're talking about an isotonic decrease in the fluid compartment. So what that means is we're not worried about the concentration of the fluid, okay? It's isotonic, so the concentration of the fluid is not going to change with this imbalance. It's only the amount or the volume of fluid that's present that's different. Does that make sense? So you remember that sodium basically controls the concentration of extracellular fluid, right? Sodium is the substance that you have the most of in that extracellular fluid, so it's basically going to control the concentration of that fluid. If we're going to have an isotonic fluid volume deficit, that means that we have to not only lose water, but also a proportionate amount of sodium that goes with it as well. Otherwise, you would not just have a volume problem, you would also have a concentration problem, right? So if you want to lose fluid but have it be the same isotonic concentration, then you have to lose not just water, but also the proportionate amount of sodium to go along with it. In this diagram, you see 3 solutions, right? And let's say that's water and the little black dots are sodium mixed in that water. Okay, the picture on the right is what would happen if you only lost fluid and didn't also lose sodium. Do you see how in that solution, not only do we have less fluid volume, but the fluid that's left is more concentrated, right? So that would not be isotonic anymore. If you want to have an isotonic fluid volume deficit, then you have to have what we have in the picture on the left. In that solution, I've kind of marked it so that you can see we've lost not just fluid volume, but also a proportionate amount of the sodium that goes with it. So what's left below that solid red line is a lower fluid volume, but notice how the concentration of that fluid is still the same. Okay, that's what we were talking about in an isotonic fluid volume deficit. We've lost both fluid and sodium. So do you see how this is truly just a volume problem? There's not enough fluid volume, but it is not also a concentration problem. Does that make sense? So if you have less fluid, a fluid volume deficit, then you'd expect there to be a lower blood volume as well, right? Because you remember the large majority of your blood is water, right? So if you have fluid deficit, you're going to have a lower blood volume. We call that hypovolemia. Hypo meaning less, vol is for volume, and then emia refers to blood. Okay, so we have a low blood volume, which means we do have the potential for impaired circulation. And if you have a lower blood volume, what would you expect to happen to your blood pressure? It's going to drop, right? So we expect to see some degree of hypotension. How low the blood pressure drops depends on how severe the fluid deficit is. If it's pretty big, okay, then the blood pressure will be low all the time. In fact, if it's very severe, patient might even go into hypovolemic shock, right? But if the fluid deficit is milder, okay, you might see what we call orthostatic hypotension or postural hypotension, meaning that the blood pressure is normal when the patient's lying down, but when you put them in the upright position, their blood pressure is going to drop. So postural has to do with position, right? The reason for the orthostatic change in vitals has to do with gravity. Okay, if the patient doesn't have much blood volume, when you put them in the upright position, more of that blood's going to end up in their lower extremities just due to gravity, and so you're going to see a drop in their blood pressure. So a lot of times if we want to tell whether our patients have some degree of fluid volume deficit, we'll measure orthostatic vitals, lying, sitting, and standing. Now you remember that when the blood pressure drops, the compensatory mechanism that the body activates is it increases the heart rate, right? Because the increased heart rate is the body's attempt to bring the blood pressure back into normal range. The other thing that will change besides the rate of the pulse is the quality of the pulse. It'll be much weaker, right? Because there's not that much blood being pumped out. So when you're feeling a radial pulse, you're not going to feel it beating so strongly against your fingers. We usually describe that as a thready or a thin pulse. Okay, so notice that thready or thin does not refer to the rate, but to the quality of the pulse. The other change in vital sign that we expect to see in our patients with fluid volume deficit is a change in the body temperature. Now, if the person has less blood volume, do you think that their body temperature is going to go up or down? Okay, so this one's a little counterintuitive because the body temperature actually goes up when there's a fluid volume deficit. Here's why. Okay, you remember when we talked about the circulatory system, we said that one of the jobs of circulation is to transport heat from the core of the body to the surface of the skin so it can be dissipated into the environment, right? If you have less blood volume, then not as much heat is going to get carried to the surface of the skin. We're not going to be able to get rid of that heat, so it gets retained and the body temperature goes up. Does that make sense? I want to mention a few additional symptoms of fluid volume deficit, including poor tissue turgor. Okay, I think you've already learned how to assess tissue turgor in health assessment. You kind of pinch the skin and see how long it takes to return to its normal position. And if it takes a long time to return to its original position, then that reflects poor hydration, right? So we'd expect decreased tissue turgor. Of course, that's really only for younger people, right? Because tissue turgor can also measure the elasticity of the skin. And in older people, even if they're not dehydrated, they're going to have poor tissue turgor because their skin just has lost its elasticity. But in younger people, you can use tissue turgor to assess fluid status. If you had somebody with decreased fluid volume, would you expect them to gain weight or lose weight? Lose weight, right? Because fluid is heavy. And you remember our little rule of thumb, right? Every pound of weight somebody gains or loses represents about 500 milliliters of fluid. We could also measure their urine output. Okay, if somebody has a decreased fluid volume, would you expect their urine output to go up or down? It should go down, right? Because the body will know that it doesn't have enough fluid, and it's going to want to try and save as much fluid as it can. So there's going to be less urine output, and they might complain of being thirsty. All right, logical interventions for isotonic fluid volume deficit. What do you think? Yeah, let's replace the fluid, right? If the patient can drink, we'll give them something to drink, preferably some kind of isotonic electrolyte solution, right? If they can't drink, we'll give them IV fluid, right? And then we have to try and identify the cause of the fluid volume deficit and fix it, right? Because if we don't do that, we can replace all the fluid we want, but they'll just keep losing it and the problem will persist. So identify the cause, fix it if we can, and then, rehydrate. Does that make sense? All right, what about the opposite problem? Isotonic fluid volume excess. Okay, excess means too much, right? So now we have too much fluid volume in the body, which is why we sometimes refer to isotonic fluid volume excess as fluid expansion or fluid overload, okay? Too much. It probably wouldn't surprise you to know that the book's definition of isotonic fluid volume excess is an isotonic expansion of extracellular fluid, okay? So again, we're talking about an expansion in the extracellular fluid compartment, not in the cells, but the extracellular fluid compartment. And again, we're talking about an isotonic increase, right? So we aren't just gaining fluid, we're also gaining a proportionate amount of sodium to go with it. So again, even though the fluid volume changes, the concentration of the fluid present should not change, okay? So we're gaining not just fluid, but a proportionate amount of sodium to go with it. So this would truly just be a volume problem and not also a concentration problem. So if we go back to our picture of the solutions with different concentrations, the solution in the center is what would happen if you only gained fluid but did not also gain a proportionate amount of sodium to go with it. You'll notice that that would not be an isotonic fluid expansion, right? That solution got more dilute, right? Because we didn't gain sodium along with it. So that would not be an isotonic increase. If you look at what I added to the picture on the left, okay, I added not just fluid, but I also added some of the black dots that represent the sodium. So that is what we're talking about here. There is an increase in the amount of fluid, but no change in the concentration of that fluid. So it is an isotonic fluid volume increase. And the big concern that we have when people have an isotonic fluid volume excess is now they're going to have hypervolemia, a greater than normal blood volume. Okay, so an increased blood volume. Now, if the blood volume is larger, what is that going to do to the blood pressure? It's going to increase, right? So now we have people with hypertension. And while an increase in blood volume does not necessarily change your heart rate, it will change the quality of the pulse. Now when you're feeling your patient's radial pulse, you're going to feel it just pounding against your fingers because there's so much blood being pumped out with each beat. It's going to be what we describe as full or bounding. Okay, so notice if we say the patient has a bounding pulse, we are not referring to the heart rate. We are referring only to the quality of the pulse. It's very strong. What else are we going to see when the blood volume increases? Well, probably those distended jugular veins again, right? Because now there's more blood in those veins than there usually is. What would you expect to happen to the patient's weight? Yeah, it's going to go up, right? And when you think of somebody with a lot of extra fluid in their body, what do you usually think? Edema, right? So we might see some peripheral edema, if you check out their ankles or their feet, or if you've got somebody who's in bed, you look at the sacral area, you would expect to see some of that dependent edema present. But remember, there are other kinds of edema besides just peripheral edema. There might be pulmonary edema as well, right? And how do you tell if your patient has pulmonary edema? The easiest way is to just listen to the lungs, right? And you can hear the sound of air moving through fluid. What do we call it? Crackles. All right, so what would the logical interventions for isotonic fluid volume excess be? Well, that would probably depend on how severe the fluid excess is. If it's not too bad, we might just restrict fluids. And we would probably also have to restrict sodium in that situation because, the more sodium in the body, the more fluid you're going to retain. If, however, the fluid excess is more severe, maybe the patient's already got crackles and is having some oxygenation issues because of it, we might give diuretics, right? Medications to try and increase the urine output so we can get rid of some of that extra fluid more quickly. All right, let's switch gears now and talk about electrolytes. Everybody knows what an electrolyte is, right? An electrolyte is a substance that develops an ionic charge or an electrical charge when it's dissolved in water. And when we write the little chemical symbols for the electrolytes, the Na for sodium, the K for potassium, the Cl for chloride, there are the little pluses and minuses that go with it, right, to indicate the electrical charge and whether it's positive or negative. And that's as opposed to something like glucose, right? When we write the chemical formula for glucose, it's C6H12O6. Are there any pluses and minuses that go with it? No, because glucose is not an electrolyte.
Okay, so we said that electrolytes are ions that develop an electrical charge when we dissolve it in water. So you remember the positively charged ions are called cations, and the negatively charged ones are called anions. Okay, and these electrolytes have a lot of important uses. For example, they're very important in fluid balance, in pH balance, plus
that little electrical charge is what facilitates action potentials, which we need in order for our nerve cells and our muscle cells to function. So some people say that electrolytes are like the spark plugs that make the body work. Now, there are actually a lot of electrolytes in the body, but we're only going to talk about what I call the big three, okay? Sodium, potassium, and calcium. And to me, the easiest way to approach electrolyte imbalances is to first review what the functions of those electrolytes are, and then to imagine what will happen if there's not enough of those electrolytes or if there's too much. Okay, so we're going to approach the topic from that very logical standpoint. Let's talk about sodium first. Sodium is the electrolyte you have the most of in your body, and the majority of it is in your extracellular fluid because of the activity of the sodium-potassium pump. You remember that the sodium-potassium pump pumps the potassium into the cell and the sodium out of the cell. Now, sodium has several functions in the body, but I only want to talk about the ones that I think are going to be most helpful to you in remembering what the symptoms of sodium imbalance are. So the only one that I want to mention here is that because sodium is the major cation in your extracellular fluid, it basically is the thing that controls the concentration of the extracellular fluid. And because it controls the concentration or the tonicity or the osmolality of that extracellular fluid, it's basically the thing that's going to control whether the cells are going to shrink or swell, whether fluid's going to move into the cell or out of the cell. Let's first talk about hyponatremia, which is what we call it when there's not as much sodium in the extracellular fluid as there usually is. Now, hyponatremia is kind of an interesting condition because there are two ways you can get it. You can get it by losing sodium, by depleting the sodium in your extracellular fluid. We call that depletional hyponatremia. But you can also become hyponatremic by keeping the same amount of sodium in your extracellular fluid, but gaining a whole bunch of extra water there. So basically what we're doing by adding that extra water is we're diluting out the sodium in the blood. So now we have dilutional hyponatremia. Both types are going to cause low blood sodium levels. Interestingly enough, dilutional hyponatremia is the more common type, and it is what happens when you retain water. Sometimes we refer to dilutional hyponatremia as water intoxication. Have you ever heard that term? So we've taken on a bunch of extra water, we've diluted out the sodium, and now we're hyponatremic. So what you see in that middle solution in this picture, that's dilutional hyponatremia. So you notice we've gained water, but we have not gained a proportionate amount of sodium to go with it. So now we have diluted out the sodium, and that solution now has a lower concentration. A good example of something that can cause dilutional hyponatremia would be what you see happen in people who do these long endurance events like the Ironman triathlon or something like that, where they're exercising for long periods of time, they're sweating a lot, and when you sweat you lose both water and sodium, right? But sometimes when people do these events, they'll lose water and sodium in their sweat, and maybe they only replace the water. They're drinking plain water instead of an electrolyte solution. And so now you're going to have somebody with a dilutional hyponatremia because they replaced the water, but they didn't replace the sodium, so now they are hyponatremic. Now, if someone becomes hyponatremic, that means the concentration of their extracellular fluid is going to drop, right? So their extracellular fluid is going to become hypotonic. Now, if the extracellular fluid is hypotonic, which way is water going to move? Into cells or out of cells? It's going to move into cells, so the cells are going to swell. Okay, the first place you're probably going to notice that is when the brain cells start to swell, because the neurosymptoms are pretty obvious. For example, if it's just a mild hyponatremia, mild swelling of the brain cells, you might see people who complain of headaches or who are lethargic. As the hyponatremia gets worse, they might complain of nausea. They might have some motor weakness. And when it becomes more severe, now we're going to see people who are confused, maybe even having seizures or falling into a coma. Worst case scenario, when it gets really bad, people can actually die. As a matter of fact, several years ago, there was a story about a radio station who was having a contest to see who could drink the most water without going pee. Unfortunately, the winner of that contest developed this dilutional hyponatremia that was so severe that she started having seizures and she actually died from that. And the really sad thing about that story was there was a nurse who was listening to the radio show that morning, and she called in and said, you guys are doing this really dangerous thing. And they just blew her off. Okay, so hyponatremia can be a dangerous thing if it becomes really severe. Now, you also know that sodium plays a big role, along with potassium, in the generation of action potentials. And so you might expect that sodium imbalances will cause problems with generating action potentials. And that can happen, but, the effects of the hyponatremia on the swelling brain cells kind of overlaps with the symptoms of problems with the generation of action potentials. So, if you just remember, neuro symptoms because of the brain cells swelling, that should cover all your bases. As far as interventions go, that's going to depend on whether it's a depletional or a dilutional hyponatremia. If it's depletional, if we've actually lost sodium, then we're going to want to give some sodium or some saline in the IV, right? Probably normal saline. If it's dilutional, then we'll want to restrict water. If it's both, or if the patient's already having neurological symptoms, then we're probably going to get a little bit more aggressive. Instead of just giving normal saline, we'll probably give some hypertonic saline. And instead of just restricting water, we'll probably give a diuretic to try and get rid of some of that water more quickly. And then, of course, we want to try and identify the cause of that dilution or that depletion, right? Because once we identify the cause, we can hopefully fix it so that the problem doesn't continue and we don't have to keep intervening. Does that make sense? All right, what about the opposite problem, hypernatremia, or higher than normal levels of sodium in the blood? Well, there are also two ways you can become hypernatremic. First of all, you can actually take in a whole bunch of extra sodium. For example, are patients who are near drowning victims in the ocean. They might have taken in a whole bunch of ocean water, and seawater is really salty. And so those people can become hypernatremic because they took in so much extra sodium. Or you might have somebody who can't eat and so is receiving a fairly concentrated tube feeding, and maybe we're not giving enough additional water along with that. That person could become hypernatremic because the tube feeding has a whole bunch of extra sodium in it. The other way to become hypernatremic, though, is to lose a bunch of water without losing a proportionate amount of sodium. So that situation would be like the solution you see on the right, where we've lost fluid but we didn't lose sodium. And so now we're hypernatremic. That solution is very concentrated. An example of when that might occur might be somebody who has maybe a deficiency of antidiuretic hormone. Antidiuretic hormone makes you save water. If you don't have enough antidiuretic hormone, you're going to lose water, but not lose sodium. And so you can become hypernatremic. Or you might see somebody who, for some reason, can't drink water. Okay, they're going to become hypernatremic as well. Now, if you're hypernatremic, your extracellular fluid is more concentrated than normal, so you are hypertonic, right? And if you're hypertonic, which way is fluid going to move? Into cells or out of cells? Water is going to move out of cells, so the cells are going to shrink. We say we have intracellular dehydration. And the symptoms of intracellular dehydration are probably what you would expect. Dry skin, dry mucous membranes because we're not making much saliva, we're not making much tears. If you have a baby in the newborn nursery who's hypernatremic, they might be crying, but there's no tears. When the brain cells shrink, again, you're going to see neurosymptoms because, it doesn't really matter whether your brain cells are shrinking or swelling. They're not going to be able to function normally, right? So we expect to see the headache, the, seizures, the coma, similar kinds of symptoms. So whether you suspect hyper or hyponatremia, you should be doing neurochecks, right? Assess the person's neurological status. Now, because a lot of times hypernatremia is the result of losing water, you might actually see some symptoms that are similar to what you would see when there's a fluid volume deficit. They might lose weight. They might feel thirsty. Their body temperature might go up. Okay, so it's, if you can distinguish whether the patient has hypernatremia because they gained sodium or because they lost water, then you would be able to tell whether you should also expect to see those signs of water loss. Does that make sense? Again, interventions are going to depend on why the patient became hypernatremic. If they became hypernatremic because they took on too much sodium, then we would want to restrict sodium intake. If the hypernatremia is a result of losing water, then we'd want to replace the lost water, and hopefully the extracellular sodium levels will normalize out again. Does that make sense? Moving on, let's talk about potassium now. So you remember potassium is also positively charged, so it's a cation, but it's primarily in the intracellular compartment, again because of the sodium-potassium pump, right? Sodium-potassium pump pumps the potassium inside the cell. Now, potassium also has several functions, but again, I only want to mention the ones that are going to be most useful to you in remembering what the symptoms of potassium imbalance are. So I'm going to only mention two. The first one is, I want to remind you that potassium plays a key role in generating action potentials. So it's very important in the function of nerve cells and muscle cells, because those are the ones that use action potentials to communicate. The other role of potassium in the body that I want to mention is that it does influence acid-base balance, and it does so through a compensatory mechanism called the plasma potassium hydrogen ion exchange. Okay, the plasma potassium hydrogen ion exchange. Okay, so what happens in this compensatory mechanism is if the blood potassium levels drop too low, remember there's a whole bunch of potassium inside the cell because the sodium-potassium pump pumped all the potassium in there, right? So if the blood potassium levels drop too low, we can shift some potassium out of the cell into the blood to kind of bring the blood potassium levels back more towards normal. But if we're going to do that, something else that's positively charged has to shift into the cell to take the place of the positively charged potassium that left. Okay, and what usually goes inside is hydrogen. And you remember in terms of acid-base balance, hydrogen ions are acid, right? Now, this compensatory mechanism can also work the opposite way. If you get too much acid in the blood, okay, we can shift some of those hydrogen ions inside the cell to buffer so that the pH of the blood is not quite so acid. But if we're going to shift the hydrogen ions into the cell, something else that's positively charged has to shift out, and what shifts out is the potassium. So you see how the potassium and the hydrogen ions can kind of compensate for each other, right? Changes in potassium levels can affect where hydrogen moves in the body, and so it's going to affect the pH, and changes in pH can also affect where the potassium is going to move, and so those two ions can try and compensate for problems in the levels of the other one, and so we have potassium actually influencing acid-base balance. Does that make sense? All right, now that we've talked about those two roles of potassium, let's see what that means for potassium imbalances. Hypokalemia. Hypo means less. K is the chemical symbol for potassium. Emia is blood. So what are the symptoms of hypokalemia, low blood potassium levels? Okay, let's think about one of the roles that we just talked about that potassium plays. When there's low blood potassium, remember there's a lot of potassium inside the cell, so we're going to shift some of the potassium out of the cell into the blood to bring that blood potassium back towards normal. But if the positively charged potassium leaves the cell, something else that's positively charged has to shift into the cell to maintain that electrical balance. And what's going to move in? The hydrogen. right? So when potassium shifts out of the cell, hydrogen shifts in, the pH of the blood is going to change, right? So whenever somebody becomes hypokalemic, we expect to see some degree of alkalosis, right? Because we have less acid in the blood, so the blood becomes more alkalotic. The other role of potassium that we mentioned was that potassium is very important in the generation of action potentials. So let's review a little bit about the action potential and see if we can figure out what effect hypokalemia is going to have. Okay, so remember, we know that the cell membrane is permeable to potassium, right? So if potassium wants to move down the concentration gradient, which way does it want to move? Into or out of the cell? It's going to want to move out of the cell, right? Down the concentration gradient. Now, if you have less potassium than normal outside the cell, what is that going to do to the amount of potassium that's going to diffuse out of that cell? More potassium is going to leave the cell, right? And if more of the positively charged potassium leaves the cell, that means the cell is going to be even more negative on the inside than it usually is, right? And if it's more negatively charged on the inside than usual, that means more sodium is going to need to enter that cell in order to depolarize that cell. So if more sodium is going to need to enter that cell, that means it's going to be harder to generate an action potential. So if you see a patient who is hypokalemic, you're going to see symptoms that are associated with it being harder to generate an action potential. And you remember, action potentials are primarily used by nerve cells and muscle cells. So let's think about what this is going to mean. The most obvious symptoms that we're going to see are the effect of the hypokalemia on the different kinds of muscles in the body. So what about skeletal muscles? If it's harder to generate an action potential with your skeletal muscles, what symptoms would you expect to see? Muscle weakness, fatigue, maybe muscle cramping, things that indicate that there's muscle dysfunction. Okay, what about heart muscle? Okay, if it's harder for heart muscle to generate action potentials, we're going to see maybe cardiac dysrhythmias, a drop in cardiac output, which might mean changes in blood pressure. All right. What about smooth muscle? Like, let's think about the smooth muscle in your GI tract. If it's harder to generate an action potential, what would you expect to see? Maybe decreased bowel sounds, decreased peristalsis, and if there's decreased peristalsis, there might be some degree of nausea, intestinal distension, constipation. Okay, now of those kinds of problems that we just mentioned, which of those do you think is going to kill you first? Probably the cardiac dysrhythmias and the drop in cardiac output, right? So when you have somebody that you suspect has a potassium imbalance, your highest priority concern should always be cardiac function, cardiac dysrhythmias, okay? The other things are going to happen, but your highest priority should be the heart because, the most important muscle in your body is your heart. If your heart's not working, you die, right? One last symptom of hypokalemia I want to mention is polyuria. Okay, poly means many or lots, right? And urea, of course, refers to urine. So polyuria means a large urine output. And the reason why we tend to see polyuria in hypokalemia is because the kidneys are like, wow, I hardly have any potassium. I should save what potassium I have, right? So the kidney is trying to save whatever potassium you have. And you remember that sodium and potassium sort of go opposite to each other, right? So if the kidney's saving potassium, that means it's dumping sodium. And when the kidney dumps the sodium, water follows. Remember, water is like the little dog that follows sodium around. So if the kidney is dumping sodium, water's going to follow. We're going to have a large urine output. And of course, if you have a large urine output, people are probably going to be complaining of being thirsty, right? And of course, the logical intervention for hypokalemia would be to give potassium replacements, right? If the patient can swallow, we might replace the potassium in the form of a pill or a solution that they drink. If the patient cannot swallow, then we're going to add the potassium to the IV. Probably we'll add it to a liter of IV solution and infuse that solution over maybe the next 8 to 10 hours. What about the opposite problem, hyperkalemia, higher than normal levels of potassium in the blood? As you might expect, the symptoms of hyperkalemia are basically the opposite of hypokalemia, especially in terms of the ability to generate action potentials. In hypokalemia, we said it became harder to generate an action potential. So you might expect that in hyperkalemia, it becomes easier to generate an action potential. And that's exactly what happens in mild hyperkalemia. If the hyperkalemia is severe, then something else happens. Okay, so let's look at those two different situations, starting with mild hyperkalemia. Okay, so you remember that the cell membrane is permeable to potassium, right? So potassium is going to want to diffuse down the concentration gradient. Okay, if you have hyperkalemia, that means there's more potassium outside the cell than usual, and so there isn't as big a concentration gradient. So what do you think that's going to do to the amount of potassium that's going to diffuse out of this cell? Since the gradient is not as big, there isn't going to be as much potassium leaving the cell, which means the cell is not going to be as negative on the inside as it usually is. Okay, and if it's less negative on the inside than it usually is, that means less sodium will need to enter that cell in order to depolarize it, so it becomes easier to generate an action potential. Okay, so what kinds of things would you expect to see if it's easier than normal to generate an action potential? Well, in terms of nerve cells, we're thinking maybe numbness and tingling in the lips or in the fingers, because it's easier to generate those action potentials and depolarize those nerve endings. In terms of muscle cells, there might be an increase in peristalsis in the smooth muscle of the GI tract, maybe a little diarrhea, but the symptoms of mild hyperkalemia are usually not that severe. Remember, it's only a mild imbalance. Some people might not even notice any symptoms, and those who do notice the symptoms, they're going to be relatively mild. What happens, though, if the hyperkalemia is severe? If there's a whole bunch of extra potassium outside that cell, we've kind of lost our concentration gradient, right? So what is that going to do to potassium moving out of that cell? If there's no concentration gradient anymore, that means potassium can't diffuse down the concentration gradient out of the cell anymore. So the cell stays positive on the inside. What happens is at some point the cell depolarizes and then cannot repolarize, right? If the cell can't repolarize, it can't depolarize again, and so there's no ability to generate action potentials. So if we think about what happens in terms of the different kinds of muscle cells, if your skeletal muscle cells aren't depolarizing, you've got somebody who's basically paralyzed. Right? If the smooth muscle is not depolarizing, you've got somebody who has no peristalsis, and nothing's going to happen in that GI tract. If the heart muscle cells can't repolarize, what happens? Patient goes into cardiac arrest, right? So one quarter when we talked about this, somebody raised their hand and said, so does that mean if I accidentally give my patient too much potassium, they could die? What do you think the answer to that is? Yes, they can. So we have to be very careful. There's a reason why we're making you learn all this stuff. It's not to torture you. It's not just useless facts that you have to, learn on your way to graduation, but these are things that you need to know in order to be safe when you're working with your patients. About the time that I was a new grad, there was an incident that happened at the hospital where a nurse was working a double shift in the ICU and was really tired. She was supposed to give her patient Lasix IV push and then to add potassium to the IV bag. And she was so tired she accidentally gave both IV push. Okay, you never push potassium straight into an IV line. You can add it to a liter of IV solution and infuse that solution over the next 8 to 10 hours, but you can't push it directly into the IV line because then all that potassium hits the blood at the same time. The patient becomes severely hyperkalemic and can go into cardiac arrest. Okay, so never push potassium IV. All right. As far as interventions for hyperkalemia, that's probably going to depend on how severe the hyperkalemia is. If it's pretty mild, we might just put the patient on a low potassium diet. If it's a little higher than that, then we do have medications that we can give to promote the excretion of potassium from the body, either in the urine or in the GI tract. I'm not going to ask you to learn those drugs right now. You'll probably talk about them as you go through your adult health sequence. But for now, I just want you to know that there are some medications that we can give that would help the body to get rid of some of that extra potassium over the next several hours. If the patient's already having cardiac dysrhythmias and that kind of thing, we would probably put the patient on dialysis so that we can try and remove some of that extra potassium in the space of just a few hours instead of several hours. All right, let's move on to calcium. Calcium is one of the major divalent cations in your body, meaning that it carries two positive electrical charges. So a lot of times when you see the chemical symbol for calcium, you'll see either two little plus marks after it or it'll say 2+. Now, I'm sure you know that the majority of the calcium in your body is found in your bones and your teeth. The small amount of calcium that's not in your bones and teeth is in the body fluids, and of the calcium in the body fluids, most of it is inside the cell, in the intracellular fluid. There is a tiny amount of calcium, though, in your extracellular fluid. And actually, that's the calcium that is involved in calcium imbalances. So when the amount of calcium in the extracellular fluid changes, that's when we're looking at the symptoms of calcium imbalance. Now, the thing to remember about the calcium in that extracellular fluid is about half of that calcium is in the blood attached to plasma proteins, bound to plasma proteins, primarily albumin. And the calcium that's attached to albumin can't leave the blood and go into cells and participate in cellular activities, right? Because albumin is big, that it can't leave the blood vessel. So if you have calcium attached to albumin, it's stuck in the blood. So it's only the calcium that's free, or sometimes we call it ionized calcium, that can actually leave the blood vessels, go into the cells, and participate in what's going on inside the cell. Now, sometimes we can see changes in whether calcium is attached to albumin or not. There are things like maybe changes in the pH of the blood, or, giving certain kinds of drugs to people that might change how much of the calcium is bound to albumin and how much is free or ionized. And if you have those kinds of changes in the amount of free or ionized calcium, then we might start seeing signs of calcium imbalances. Now, calcium does a ton of things in the body, but the only function that you really need to think about when you're trying to remember the symptoms of calcium imbalance is its role in helping to generate action potentials. Now, maybe you're thinking, when we talked about action potentials in the beginning of the quarter, I remember talking about sodium and potassium, but I don't remember talking about calcium. And that's because we didn't. But the thing is, even though calcium doesn't play as direct a role in generating action potentials as sodium and potassium does, it does affect how hard or easy a time sodium has entering the cell to depolarize it. So I think of calcium as the membrane stabilizer. See that stuff that's circled in green? Calcium is the membrane stabilizer. In other words, when calcium is present, it's harder for sodium to enter the cell and depolarize it. So you remember, in order to generate an action potential, the potassium first diffuses out of the cell and makes it negative on the inside, and then the sodium enters the cell and depolarizes it. Okay? Calcium is the membrane stabilizer, right? It makes the membrane very stable. In other words, it's hard for sodium to enter the cell and depolarize it. On the other hand, if calcium is not present, then the membrane is not very stable. It's easy for sodium to cross into the cell and therefore easier to generate an action potential. Okay, so that's really all you need to think about when you're trying to remember the symptoms of hyper and hypocalcemia. So based on that, what do you think the symptoms of hypocalcemia are going to be like? Well, calcium's not present, so the membrane's not stable. It's easy for sodium to enter and depolarize the cell. So now we're going to see signs of increased membrane excitability, it being very easy to generate action potentials. So we're going to see things like paresthesias. Because the nerve endings are firing out of control, we have all these, tingling, maybe numbness, maybe the pins and needles kinds of feelings because of how easy it is to generate action potentials for those nerve endings and receptors. We might also see what we call tetany. And tetany is a word we use to describe when people get like muscle spasms and twitching of the face, the hands, the feet, sometimes the extremities, but usually the little muscles in the face, the hands, and the feet. We're going to see the twitching and the little spasms. We might also see what we call laryngospasms, or some people call it laryngeal spasms, where the smooth muscle around the airways goes into spasm and constricts down really tight. So there's major airway narrowing, almost like an airway obstruction. So lots of wheezing. And then, of course, there might be some seizures, action potentials firing out of control. We might see the seizure activity, where the arms and legs are kind of jerking. And there might also be some cardiac dysrhythmias, right? If it's easier than normal to generate action potentials in the heart muscle. So I found this little mnemonic on Google Images called the CATS of hypocalcemia, and that's just a little acronym to remind you, convulsions or seizures. There's the cardiac dysrhythmias, the tetany, and then the laryngeal spasms. Stridor is just a word that refers to the very high-pitched, really harsh kind of wheezing sound that you hear when the major airways are really narrow. Now, the first quarter that I used this little mnemonic, students would say, well, when I got to the test, I remembered the CATs, but I couldn't remember whether the CATs went with hyper or hypocalcemia. So, it actually works better if you just think through the logic of whether it's harder or easier to generate action potentials, whether the membrane stabilizer is present or not. But if you want to use the mnemonic, one of the ways that you might try and remember whether the CATs go with hyper or hypocalcemia is remember that cats aren't hyper, right? Cats are not hyperactive. Cats just kind of lay around all day. So they're more on the hypo side than on the hyper side, right? But anyway, think through the logic, okay, just to double check yourself. As far as interventions for hypocalcemia, the logical thing to do would be to replace the calcium, right? And since the symptoms that we've been talking about are fairly acute, we'll probably replace the calcium through the IV. Now, I do want to say that there is such a thing as a chronic hypocalcemia, right? What we've talked about is more acute. The symptoms come on suddenly, they're fairly severe, but there is a situation where, people might be more mildly hypocalcemic. It comes on much more gradually. The symptoms aren't, severe and immediately apparent like they are with acute hypocalcemia. What do you think the primary sign of chronic hypocalcemia would be? Probably weak bones, right? Osteoporosis, bones that fracture easily, maybe even some bone deformities. In the case of chronic hypocalcemia, we would probably do oral calcium supplements. And, if we're going to do oral supplements, we probably also need to give some vitamin D supplements to help the body absorb the calcium. What about the opposite problem, hypercalcemia, where we have higher than normal levels of calcium in the blood? Well, as you might expect, we see the opposite kinds of problems. There is a decrease in membrane excitability, so it becomes harder to generate an action potential. Remember that calcium is the membrane stabilizer, right? So if there's too much calcium present, that membrane is going to be extremely stable, meaning it's hard for sodium to enter that cell and depolarize it. So it's going to be harder than normal to generate an action potential. Okay, so if it's hard to generate action potentials, we're going to see muscle weakness, and the muscles are going to be what we call flaccid, meaning they're just kind of limp, right? No muscle tone, no reflex activity, they're just really basically not doing much. Okay? If the smooth muscle in the GI tract is not having action potentials, we're going to see constipation, decreased or absent bowel sounds, nausea, vomiting, because things aren't moving on through. And of course, if the brain cells are having trouble generating action potentials, we're going to see what we call stupor. Do you guys know what stupor means? Because it's not the same as stupid, right? Stupor just refers to where people are so lethargic that it almost seems like there's not much activity going on in their brain at all. Their eyes may be open, but they're not responding. They're just really out of it, okay? And then, of course, if we're talking about the heart muscle having trouble generating action potentials, then we're going to see cardiac dysrhythmias. Now, those are the things that we're going to see if it's an acute hypercalcemia, right? It comes on suddenly, it's very severe. But remember, there can also be a chronic hypercalcemia, where the high calcium levels come on much more gradually over a longer period of time. What do you think the primary problem is going to be for people who have chronic hypercalcemia? Kidney stones, right? Because a large majority of kidney stones are calcium-based. As for interventions for hypercalcemia, mostly what we do is we try and figure out why the calcium levels are high and fix that problem if we can. So, for example, if it's caused by a parathyroid disease, we'll try and treat that. If it's a bone disorder, we'll try and fix that. Then, put people on a low calcium diet. We do have medications that we can give to try and promote the excretion of calcium from the body. And again, I'm not going to burden you with those at this point, but you will learn about those later on. And we actually might give people some of the drugs that we use for osteoporosis, because our goal here is to keep the calcium in the person's bones so it doesn't enter the blood and keep raising the blood calcium levels more, right? So there are certain osteoporosis drugs that we might use to try and prevent the calcium from leaving the bones and entering the blood. All right, to review the electrolytes, okay, if you suspect a sodium imbalance, what body system do you check? Neuro. Okay, if you suspect a potassium imbalance, what body system is your priority? The heart, right? Because potassium is involved in action potentials, which you need for muscle function. The most important muscle in your body is your heart. Okay, and then for calcium, remember, calcium's the membrane stabilizer. When it's there, the membrane's stable, it's harder to generate an action potential. If it's not there, the membrane's not stable, it's easier to generate an action potential. All right? You just remember that, think it through during the test, you'll be good. All right, we're going to spend the rest of our time talking about acid-base balance and imbalance.
Some general concepts, okay? In order for the body to function normally, the pH of the body fluids has to be within a fairly narrow range, somewhere between 7.35 and 7.45. Now, if you go too far outside that range in either direction, now you're going to see things like changes in membrane excitability, changes in the ability of some enzyme systems to function. You might even see some changes in the structure or the function of some of the proteins inside the cell, all of which, of course, is going to affect the ability of the cell to function normally. So keeping your body fluid in pH balance is very important. Okay, so you remember from chemistry, right, that pH is determined by the relative hydrogen ion concentration. Because remember, in terms of acid-base, when we talk about hydrogen, what are we talking about? We're talking about acid, okay? So the higher the hydrogen ion concentration, the more acid a solution is, and the lower the pH, okay? So remember that. The more acid a solution is, the smaller the number is, right? Something with a pH of 2 is way more acid than something with a pH of 6, right? So even though the more acid you get, that means the more hydrogen you have, the number gets smaller, okay? So the higher the hydrogen concentration, the more acid. The less hydrogen you have, the more alkaline, or the more basic the solution becomes. Okay, so don't get those numbers switched around.
Now, an important concept to remember when you're thinking about acid-base balance is to remember that acids are always continually being produced by the cells as a result of metabolism, right? When your cells burn fuel using oxygen to make ATP, one of the waste products is acid. And in order to keep the body's pH within normal limits, we have to get rid of those acids. There are two ways to get rid of acids from your body, your lungs and your kidneys. Now, the lungs can only get rid of carbonic acid because carbonic acid is the only one that is a volatile acid. Volatile meaning that carbonic acid can be easily vaporized. It can be changed into a gas so it can be exhaled from the body by the lungs in the form of carbon dioxide. Remember this equation? Okay, that's carbonic acid there in the middle, H2CO3. And you can see, according to this equation, that carbonic acid can be broken down into carbon dioxide and water. And then the carbon dioxide can be exhaled by the lungs. So that's how the lungs get rid of carbonic acid, by breaking the carbonic acid into carbon dioxide and water, and then exhaling the carbon dioxide. So the lungs can only get rid of the carbonic acid. The kidneys have to get rid of every other acid, because none of the other acids that are produced are volatile. Now, the lungs will actually kick in pretty quick when the pH starts getting too acid. Probably within a few minutes, the lungs will start getting rid of carbon dioxide. But the lungs alone cannot return the pH completely to normal. The kidneys, on the other hand, don't kick in quite as fast as the lungs. It takes them a few hours to get going, but once they get going, they'll keep functioning until the pH has gone back to normal. Might take several days, but the kidneys will just keep on going, trying to excrete all the other acids in the urine. So the two make a pretty good team. The lungs kick in right away. The kidneys keep going until, the pH hopefully returns to normal. Now, it does take a while for the lungs and the kidneys to excrete all those acids from the body. And in order to prevent the pH from getting too far out of normal range while we're waiting for the lungs and the kidneys to do their thing, the body does have a few temporary mechanisms for trying to keep the pH from getting too out of balance. The two mechanisms that we have to try and, keep things from getting too out of control while we're waiting for the kidneys and the lungs to work are buffer systems and compartmental shifting. So let's say a few words about each of those two things. Starting with buffer systems. There are actually several buffer systems in your body. We have bone buffers, phosphate buffers, protein buffers, but probably the primary and most powerful buffer system in the extracellular fluid is what we call the bicarbonate buffer system. Now, lucky for you, you already know about the bicarbonate buffer system because here it is, summarized in this equation. Let me explain it to you. Okay, now a buffer system is a compensatory mechanism that's made up of an acid and a base. So here you see the two components of the bicarbonate buffer system. The carbonic acid is the acid component of the buffer, and the bicarb, HCO3, is the base component of the buffer system. And these two components usually exist in chemical equilibrium in the extracellular fluid. If, however, the pH starts getting out of control in one direction or the other, one of the two components of the buffer system are going to jump in to try and correct the problem. For example, if the pH gets too acid, the bicarb component of the buffer system is going to jump in, pick up some of that extra acid, and change into carbonic acid. Now, maybe you're wondering, how does that help? Because carbonic acid is still an acid, right? But here's the thing. Carbonic acid is a weak acid, and it's also an acid that can be easily broken down into carbon dioxide and water, and then we can exhale the carbon dioxide, right? So what this buffer system does is it changes strong acids into weak acids, and then that weak acid can be broken apart and exhaled from the body. Does that make sense? On the other hand, if the blood gets too alkaline, the carbonic acid component of the buffer system is going to jump in. It's going to dissociate out into hydrogen and bicarb. And, just by releasing the hydrogen, we've already made some acid to balance out how alkaline the blood is, right? Of course, we're also producing some bicarb, which is a base, but it is a weak base. And it's also a base that can be easily excreted by the kidneys when needed. Okay, so what the buffer system's doing this time is it's taking strong bases, converting them to weak bases, and bases that can be easily excreted from the body, and it's also releasing a little acid to counterbalance the alkalinity of the body fluid. Okay, so it's a very efficient system because the two components of this buffer system, the carbonic acid and the bicarb, can be easily produced or gotten rid of from the body by the lungs and the kidneys. And I also think it's kind of cool because it's taking a waste product like carbon dioxide and changing it into something that can be used by the body to keep it in acid-base balance. Pretty cool, right? Compartmental shifting is the other temporary mechanism that we said that you have to try and keep your pH from getting too far out of whack while we're waiting for the lungs and the kidneys to actually excrete the acids from the body. And lucky for you, you already know about compartmental shifting too, because there it is, the plasma potassium hydrogen ion exchange. So you remember earlier we talked about this compensatory mechanism in relation to people who have low blood potassium levels, and we talked about shifting potassium out of the cell and hydrogen in to try and normalize out the potassium levels. But remember, we also said it can work in the opposite direction, right? If there's too much acid or hydrogen in the blood, we can shift some of that into the cell so that it's not in the blood making the blood more acid, and then we're shifting the potassium out to take its place. Okay, so can you see how in this mechanism, why by moving the hydrogen into the cell, we're keeping it out of the blood so the blood is not quite so acid while we're waiting for the kidneys to actually get rid of the acid. So it's buying us a little extra time. Okay, so in a nutshell, right, your cells are always making acids as a result of metabolism. You only have two ways to get rid of those acids, your lungs and your kidneys. While we're waiting for the lungs and the kidneys to actually excrete the acids from the body, we have the buffer systems and compartmental shifting to try and keep the blood pH from getting too far out of normal range while we're waiting for the lungs and the kidneys to do their job. Got it? The primary clinical indicator of acid-base balance is the ABG, or the arterial blood gas. Now, the ABG gives you lots of information, but there are only 3 values that we're interested in today. And I'm going to give you some normal ranges to memorize, okay, because I'm going to ask you to interpret some ABGs on the test, and you will need to know these normal values. I'm not going to give them to you on the test. Now, keep in mind that each hospital has their own set of normal values for the ABGs. And every hospital is a little bit different from each other, but they should all be in the same ballpark, okay? I'm giving you the values that are from your textbook to memorize. So the first one is the PaCO2, which stands for the partial pressure of carbon dioxide in arterial blood. The little a stands for arterial. Okay, and a normal range for PaCO2 is 35 to 45 millimeters of mercury. This is your respiratory indicator of acid-base balance. This is the value that's going to tell you how good a job your lungs are doing at keeping you in acid-base balance. So here in the slide, you can see that the PCO2 is your respiratory indicator of acid-base balance, telling you how good a job your lungs are doing. The second value to memorize is the plasma bicarb concentration, or HCO3. Normal is somewhere between 22 and 26 milliequivalents per liter, and this is your metabolic indicator. So here you can see the bicarb, or the metabolic indicator, tells you how good a job your kidneys are doing at keeping you in acid-base balance. Finally, we have the pH. Normal value should be somewhere between 7.35 and 7.45. And you remember the pH is determined by the relative hydrogen ion concentration, or the relative amounts of acids and bases in your body fluid. So what we mean by relative is it's not the absolute value of your bicarb or the carbonic acid in your blood that determines the pH, but it's their ratio, or it's their values in relation to each other that's going to determine what the pH is. In order for your pH to be within normal limits, the ratio of bicarb to carbonic acid has to be about 20:1. This picture can maybe help you visualize better what we're talking about when we're talking about the 20:1 ratio, the 20 bicarbs to 1 carbonic acid. That's the ratio that you have to have in order for the pH to be normal. Now, maybe you're looking at these numbers that we mentioned earlier and saying, that doesn't look like a 20:1 ratio to me. Okay, remember that the 20:1 ratio is bicarb to carbonic acid. These numbers are for bicarb and carbon dioxide. So the numbers aren't going to work out, but the 20:1 ratio is still important. The value of this 20:1 ratio is to help you understand how the ratio is kind of like a scale, as you see in this picture. If you get a little bit too much bicarb on board, all we have to do is retain a little bit more carbonic acid, and we can balance the scale and keep the pH normal. If we lose a little bit of bicarb, all we have to do is lose a little bit more carbonic acid, and again we can balance the scale. So do you see what I mean when I say it's not the absolute values of bicarb and carbonic acid that determines the pH, but it's their balance or their ratio. As long as we've still got that 20:1 ratio, it doesn't matter how far out of normal range the actual values are. If we've still got that 20:1 ratio, our pH can still be normal. So that's what brings into play this idea of compensation. The lungs and the kidneys can try and compensate for each other if one of those systems is messing up. You know, if the lungs are messing up and not getting rid of enough carbonic acid, all the kidneys have to do is retain a little bit more bicarb, and we can keep the scale in balance and keep the pH normal. If the kidneys are messing up and getting rid of too much bicarb, then all we have to do is get rid of more carbonic acid, and we can still balance the scale and have a normal pH. So do you see how the lungs and the kidneys can compensate for each other's problems and still keep the pH within normal limits? That idea of compensation is very important. We'll talk about it a little bit more when we actually talk about how to interpret a blood gas. So there are two basic acid-base imbalances. We have acidosis and alkalosis. Those are the terms that we use to refer to the clinical conditions that result from the changes in pH. Now, you'll notice from this slide that acidosis and alkalosis can either be classified as respiratory imbalance or a metabolic imbalance. So we have four primary acid-base imbalances, right? We have metabolic and respiratory acidosis and metabolic and respiratory alkalosis. The respiratory imbalances are all related to problems with carbon dioxide levels because of changes in ventilation. Okay, that makes sense, right? That's why we call it respiratory, because it's caused by a problem with gas exchange or ventilation. To make it easy, everything else is a metabolic imbalance. Does that make sense? Okay, a few key concepts to keep in mind. Okay, as far as symptoms of acid-base imbalances, with acidosis, the primary result is decreased membrane excitability. In other words, it's harder to generate an action potential. So in acidosis, you're going to see all those things you expect to see when it's harder to generate an action potential. And as you might expect, in alkalosis, you're going to see the exact opposite. In alkalosis, it's increased membrane excitability, meaning it's easier than normal to generate an action potential. So you're going to see all those symptoms that you would expect to see when it's easier to generate an action potential. as far as compensation goes, this should make logical sense, right? In acidosis, if you have too much acid, the body will try and compensate for or correct that problem by either getting rid of more acid or saving more base or doing both, right? And in alkalosis, you would expect to see the opposite. The body will try and compensate for or correct that problem by either saving more acid or getting rid of more base, or both. So you remember that the kidneys are the metabolic component of acid-base balance, and the lungs are the respiratory component, right? So it makes sense then that in a metabolic imbalance, it's the kidneys that are causing the problem, and the lungs are going to try and fix the problem. And the way the lungs try to fix the problem is by changing how fast or how deep you breathe, so that changes how much carbon dioxide gets exhaled, right? Remember, carbon dioxide is basically acid, right? Since all you have to do to carbon dioxide is add water and you get carbonic acid. So when you think carbon dioxide, I want you to think acid. Okay, so if the person breathes faster and deeper, they're going to get rid of more carbon dioxide and therefore more acid. If they breathe slower and shallower, they're going to save more carbon dioxide or more carbonic acid. And that's how the lungs can try and adjust the pH, right? If it's a respiratory imbalance, this time it's the lungs that are causing the problem. And so the kidneys are going to try and fix the problem. And the way the kidneys try to fix acid-base imbalances is by changing how much acids or bases it saves or gets rid of in the urine. So the way to tell whether the kidneys are doing their compensation is by checking the pH of the urine. If the kidneys are getting rid of more acids or more bases, we're going to see a change in the pH of the urine. Okay, so those are the basics. What we're going to do now is we're going to briefly walk through each of the 4 acid-base imbalances and see how those concepts play out in each one of them. And this is just like a review slide where I tried to put those main concepts on one slide so that maybe you can look at them as you think about the 4 different acid-base imbalances. All right, let's talk about metabolic acidosis first. Okay, your book defines metabolic acidosis as a primary deficit in bicarb. Okay, all that means is there's not enough base to balance out the amount of acid that's present, so we've lost that 20-to-1 ratio, and now we're to acid. Okay, now you remember we said that acidosis decreases membrane excitability, right? There's something about acidosis that seems to directly depress the membrane. Okay, so now it's harder to generate an action potential. So you're going to see symptoms like lethargy or confusion, stupor, maybe even coma, because it's harder to generate those action potentials in those brain cells. In the heart muscle cells, because it's harder to generate those action potentials, we might see a decrease in heart rate or a decrease in the force of contraction. And we might expect to see things like a drop in cardiac output or maybe some cardiac dysrhythmias. Now, since this is a metabolic imbalance, which body system caused this problem? The kidneys, right? So which body system should be trying to correct this problem or compensate for it? Your lungs, okay? And how will your lungs try to fix acidosis? Probably by increasing the rate and the depth of the respiration so we can get rid of more carbonic acid in the form of carbon dioxide. Does that make sense? So when you're assessing a patient with metabolic acidosis, there are 3 kinds of things that you should be checking on. First of all, you should be looking for signs of decreased membrane excitability. Okay, second, you should be checking the lungs to see if they're doing a good job of trying to compensate for the problem. And third, you should be assessing the symptoms of whatever problem cause the metabolic acidosis. Some common things that can cause metabolic acidosis are things like renal failure or diabetic ketoacidosis. So if you've been able to identify the cause of the acidosis, then you want to assess that problem to see if it's getting better or worse, and to see if there are things that we need to be doing to fix that problem, because the primary intervention for metabolic acidosis is to try and correct the underlying cause. All right, how about metabolic alkalosis? Your book defines metabolic alkalosis as a primary excess of bicarb. So now we've got too much bicarb to balance out with the amount of acid that's present. And again, we've lost our 20-to-1 ratio. Only this time we're too alkaline. Okay, now you remember we said alkalosis causes increased membrane excitability. So you would expect to see those kinds of things that happen when it's too easy to generate an action potential. The paresthesias, the tetany, probably confusion, and if it's really severe, you might see seizures or cardiac dysrhythmias. Okay, now since this is a metabolic imbalance, which body system caused this problem? Your kidneys, right? So which body system should be trying to compensate for it? Your lungs. Okay, and how will your lungs try and correct alkalosis? Probably by decreasing the rate and the depth of breathing, right? So we can retain more carbon dioxide, which you remember is carbonic acid, okay? And if we retain more acid, hopefully that should, counterbalance all the alkalinity and bring the pH back to something more within normal limits. The problem here, though, is basically the compensation involves hypoventilating, right? And you can only hypoventilate to a certain point before you start becoming hypoxic and getting too much carbon dioxide, right? Becoming hypercapnic. So the bottom line here is you can only compensate so much before you're at risk for respiratory failure. Intervention primarily revolves around trying to identify the cause and to correct it if we can. All right, let's talk about some respiratory imbalances now, starting with respiratory acidosis. Basically, anything that interferes with gas exchange is going to cause respiratory acidosis, whether it's impaired ventilation or respiratory depression. If we're not getting rid of that carbon dioxide, remember, carbon dioxide is basically carbonic acid, right? All you have to do is add water to carbon dioxide and you get carbonic acid. So if you have too much carbonic acid, that puts you in respiratory acidosis. So you remember that acidosis depresses membrane excitability, so you're going to expect to see headache, confusion, stupor, coma. If you think about it, those are the symptoms of hypoxia and hypercapnia, right? With the hypoxia, you get the confusion and the stupor and, poor brain function because your brain's not getting enough oxygen. If you have hypercapnia, you're going to have CO2 narcosis, right? Which is when people get really sleepy and stuff. So those symptoms there of respiratory acidosis and hypoxia, hypercapnia, they all overlap. And that makes sense, right? Now, since this is a respiratory imbalance, which body system causes this problem? Your lungs, right? So which body system should be trying to compensate for it? Your kidneys. Okay, your kidneys are going to try and correct acidosis by either getting rid of more acid in the urine or getting rid of less base. In other words, saving the base, right? And hopefully that should bring the body's pH more within normal limits. However, remember that the kidneys don't kick in quite as quickly as the lungs do. It might take 1 or more days for the kidneys to really start trying to compensate for that imbalance. So the blood pH can actually drop pretty big before that kidney compensation kicks in. The most logical intervention to fix respiratory acidosis is to just do whatever we need to improve ventilation and gas exchange, right? So again, identify the cause and try and fix that ventilation problem. Our last imbalance is respiratory alkalosis. And respiratory alkalosis is usually caused when people hyperventilate. Because when people breathe faster and deeper, they're getting rid of more carbon dioxide, meaning they're getting rid of more carbonic acid, and so they tend to become more alkaline. Some examples of things that can cause hyperventilation are things like anxiety attacks, panic attacks, maybe severe pain, because, sometimes pain makes people hyperventilate, or maybe fever, because fever also often makes people breathe faster than normal. Now, we said that alkalosis tends to increase membrane excitability. In other words, make it easier to generate action potential. So we would expect to see things like paresthesias. A lot of times when people hyperventilate, they complain of numbness and tingling around their mouth. That's the paresthesias. Okay, or maybe they'll complain of dizziness or even have tetany or seizures. Okay, all of those things are things that you see when it's easier than normal to generate action potentials. Now, since this is a respiratory alkalosis, which body system caused this problem? Your lungs. So which body system should be trying to compensate for it? Your kidneys. Okay, and how should your kidneys try and compensate for respiratory alkalosis? Well, the kidneys should be trying to excrete less acid or excrete more base in the urine. But remember that we said that it does take the kidneys a while to get going, right? And if you think about some of the more common causes of respiratory alkalosis, things like anxiety attacks or panic attacks, those are things that usually don't last very long. So it might be over before the kidney even gets around to trying to compensate for it. So you may or may not see any changes in the pH of the urine as evidence that the kidneys are trying to compensate for the problem. Does that make sense? As always, the intervention for respiratory alkalosis revolves around trying to identify the cause and to correct it if we can. Since a lot of times the alkalosis is due to anxiety or panic attacks or anything that causes hyperventilation, sometimes a quick fix is to have the patient breathe into a paper bag. Now, why do you suppose we're doing that? Yeah, we're trying to get the patient to rebreathe the carbon dioxide they exhaled, right? Because remember, carbon dioxide is equal to acid. So if they rebreathe the carbon dioxide, hopefully we're increasing the level of carbon dioxide in the body, which will, provide some acid to balance out how alkaline the body fluid is. All right. Now, I've actually simplified these acid-base imbalances quite a bit because they're pretty complex. But if you're interested in all that detail, it's all there in your textbook, so I'll refer you to that. The other thing that I want to remind you of is, remember at the beginning of this session, we said that the fluid, electrolyte, and acid-base imbalances are actually quite interrelated. I want to give you one example of how the electrolyte and acid-base imbalances are interrelated. You've probably noticed that the symptoms of alkalosis are a lot like the symptoms of hypocalcemia, right? They both cause increased membrane excitability, and so you see things like tetany and dizziness and paresthesias and so forth. There's a reason why the symptoms of alkalosis and the symptoms of hypocalcemia are similar. Okay, so you remember that we said half of the calcium in your blood is actually bound to albumin, right? And so we have some of your calcium attached to albumin, and the rest of the calcium is what we call free or ionized calcium. And it's that free calcium that actually enters the cell and participates in cellular activities, and changes in the level of free calcium are what cause the symptoms of calcium imbalance. Okay, so it turns out that calcium actually competes for binding sites on albumin with hydrogen. So as you might imagine, the more hydrogen that's present, the less calcium is going to bind. The less hydrogen present, the more calcium is going to bind, right? So you see how the amount of acid present is going to change how much calcium is attached to albumin, and will then in turn affect how much calcium is free or ionized. So let's think about what's going to happen if the patient's in alkalosis. Okay, if the patient is in alkalosis, is there going to be more or less hydrogen present? There's going to be less hydrogen present, because you remember hydrogen represents acid, right? So if we're in alkalosis, there's going to be less acid present, less hydrogen ions. Okay, so if there's less hydrogen ions binding to albumin, what is that going to do to the amount of calcium that's going to bind to albumin? If less hydrogen is binding to albumin, that means more calcium can bind to albumin. And if there's more calcium bound to albumin, what does that do to the amount of free or ionized calcium that's present? If more calcium is attached to albumin, that means there's less free or ionized calcium. In other words, now we're hypocalcemic. So do you see how that alkalosis actually sort of caused the hypocalcemia? So it makes sense then, right, that the alkalosis and the hypocalcemia symptoms are similar. Okay, so that's just one example of how electrolyte balance and acid-base balance are interrelated. But it's enough to give you the idea of the fact that there are these connections between the two. Does that make sense? All right, let's talk about some major concepts for interpreting ABGs. And actually, there are some tricks out there that nurses sometimes use to interpret blood gases, but we're going to talk about the logic behind it today, because I want you to really understand what these values on the blood gas mean. Okay, so you remember 2 of the 3 values I told you needed to memorize for the test were the PaCO2 and the bicarb. Okay, now you remember carbon dioxide is acid, right? Because all you need to do is add water to carbon dioxide and you get carbonic acid. So when you think carbon dioxide, you should be thinking acid. Okay, so if you have an increase in the PaCO2, that makes you more acid, right? Because CO2 is acid. If you have a decrease in CO2, that makes you less acid or more alkaline. Does that make sense? If you're not as acid, that means you're more alkaline. Okay? What about the bicarb? You remember bicarb is a base, right? Like sodium bicarbonate, that's baking soda. That's the thing that you used in all your high school chemistry experiments to represent base, right? So bicarb is a base. If your bicarb levels go up, you are more alkaline. If your bicarb levels go down, you are less alkaline or more acid. Does that make sense? All right, now that we have that figured out, let's actually interpret a blood gas. Okay, so at the end of your study guide, there should be a page that talks about steps for interpreting ABGs. Okay, we're going to walk through those steps. Okay, so step number 1, look at the pH. Does the patient have acidosis or alkalosis? Okay, so this patient's pH is 7.49. That's too high, so the patient's in alkalosis, right? All right, step number 2. Look at the PCO2 and the bicarb. Are they high, low, or normal? Okay, so the PCO2 is 52. That's on the high side. And if your CO2 is high, does that make you more acid or more alkaline? Makes you more acid, right? Okay, what about the bicarb? Is that high, low, or normal? The bicarb is 33. That's higher than normal. So is that going to make you more acid or more alkaline? If you have too much base, that's going to make you more alkaline, right? Now the question becomes, which of those two values cause the alkalosis? The PCO2 is making you more acid, the bicarb is making you more alkaline, so only one of those two values could have caused the alkalosis, right? Which one? Well, the bicarb is the only one making this patient more alkaline, so the bicarb must have caused the problem, right? Is the bicarb your respiratory or your metabolic indicator? It's your metabolic indicator, right? So this patient is in metabolic alkalosis. All right. The last step. Look at the value you did not choose as being the cause of the problem. Okay, so we chose bicarb as the cause of the problem. So let's look at the PCO2. Okay, does it look like the PCO2 is trying to fix the problem? Is the PCO2 trying to correct the alkalosis? Yes, it is, right? Because the PCO2 is trying to make more acid to balance out the alkalinity of the alkalosis, right? So the PCO2 is trying to correct the problem. Did it succeed in bringing the pH back to normal? No, right? Because the pH is still not within normal limits. So we say this patient has partially compensated metabolic alkalosis. Does that make sense? Okay, now if the PCO2 had succeeded in bringing the pH back to normal limits, we would say it was fully compensated metabolic alkalosis. If it looked like the PCO2 was not even trying to fix the problem, then we would say it was uncompensated. Does that make sense? Okay. Now, notice that we did not even read the little story about the patient. You actually don't need that in order to interpret the acid-base imbalance. All you need are the numbers. But if you read the little story, it does make sense, right? Because here we have a baby who had bowel surgery and has an NG tube hooked to suction, and we're sucking all the gastric acids out of this baby, right? So it makes sense, doesn't it, that the baby is now in alkalosis because it's losing its gastric acids. Okay, also notice that we didn't even look at the PO2, right? Because you don't need to know that in order to know what acid-base imbalance the patient has. Now, of course, you would want to know whether your patient was well oxygenated or not, right? That is important, but you don't need that information in order to interpret which acid-base imbalance the patient has. Does that make sense? All right, let's try another one. Okay, step 1, look at the pH. Does the patient have acidosis or alkalosis? Well, the pH is below normal, so we're in acidosis, right? Step 2, look at the PCO2 and the bicarb. Are they high, low, or normal? Okay, so the PCO2 is 55, which is on the high side, right? And if your PCO2 is too high, is that going to make you more acid or more alkaline? Well, remember, CO2 is carbonic acid, basically. So when the CO2 is high, it's going to make us more acid. Okay? What about the bicarb? Bicarb is normal, right? So that's not going to make you either acid or alkaline. All right? So if you look at the PCO2 and the bicarb values now, which of the two cause the acidosis? Well, the PCO2 is making you more acid. The bicarb is making you neither acid nor alkaline. So the only one that could have caused the acidosis is the PCO2, right? And is that our metabolic or our respiratory indicator of acid-base balance? That is our respiratory indicator, so we are in respiratory acidosis. Okay, since we decided the PCO2 was the cause of the problem, let's now look at the bicarb to see if it's trying to fix the problem. Is the bicarb trying to make us less acid? No, the bicarb is doing nothing, right? So this is an uncompensated respiratory acidosis. Okay, and if you look at the little story, that does make sense, right? Because this person has pneumonia, so they have poor gas exchange, so it makes sense that this is a respiratory imbalance, right? Another one, okay, look at the pH. Is this patient in acidosis or alkalosis? Well, the pH is 7.58, which is higher than normal, so this person is in alkalosis. Okay, what about the PCO2 and the bicarb? Are they high, low, or normal? Okay, so the PCO2 is 28, which is lower than normal. Is that going to make you more acid or more alkaline? Okay, well, remember, CO2 is acid, right? So if you have less of it, that's going to make you more alkaline, right? Okay, what about the bicarb? The bicarb is also lower than normal. And you remember, bicarb is a base. So if you have less base, is that going to make you more acid or more alkaline? If you have less base, you are less alkaline and therefore more acid. Right? So which of those two values could cause the alkalosis? The PCO2 or the bicarb? Well, the PCO2 is the one that's making us more alkaline. So that is the cause of the alkalosis. Is the PCO2 our respiratory or our metabolic indicator of acid-base balance? So the PCO2 is our respiratory indicator, so we are in respiratory alkalosis. Okay, so since we picked the PCO2 as the cause of the problem, now we need to look at the bicarb to see if it's trying to compensate for the problem. Is the bicarb trying to make us less alkaline? Yes, it is. It's trying to make more acid to counteract the alkalinity. Did it succeed in bringing the pH back to normal? No, because the pH is still outside of normal limits. So we call this partially compensated respiratory alkalosis. All right, let's do one last one. This one is a little bit more challenging because look at the pH. Okay, the pH is actually within normal limits, right? So you might wonder how you would even know that this patient had an acid-base imbalance when the pH is normal, okay? The way you know is you look at the PCO2 and you look at the bicarb and you see that those values are both abnormal. So what you know right away is this person has a fully compensated acid-base imbalance, right? The PCO2 and the bicarb are abnormal. That tells you that there is an issue, but the pH is back within normal limits. So one of these values caused a problem, the other fully compensated for it, and so the pH is back within normal limits. Okay, but in order to follow the steps of interpreting the ABG, you have to know, is this patient, or did they start out with an acidosis or an alkalosis? Okay, now what you do is you just look at the pH and you see which side it's closer to. Is it closer to the 7.35 side or the 7.45 side? Well, this patient has a pH of 7.36, so it's closer to the acid side. So we're going to say that this is a fully compensated acidosis. Okay? So now we need to decide, is this a fully compensated respiratory or metabolic acidosis? Okay, so what we're going to do is we're going to follow our steps, look at the PCO2 and the bicarb, and decide if they're high, low, or normal. Okay, the PCO2 is 50, which is high, and the higher the CO2, the more acid you are, right? Because CO2 is carbonic acid. Okay, the bicarb is also high at 29. And since bicarb's a base, the more bicarb you have, the more alkaline you are. Okay, so which one of those values caused the original acidosis? It's got to be the PCO2, right? Because that's the only value that's making you more acid. So PCO2 is your respiratory component. So we have a fully compensated respiratory acidosis. Okay, so what happened was the PCO2 went up, made the person more acid. The bicarb went up to compensate for it and succeeded in bringing the pH back to normal limits. So we have a fully compensated respiratory acidosis. Does that make sense? So there's a handout in today's module called ABG handout, okay? And it has these 4 examples that we just walked through with a written explanation of, how we interpreted it. So if it helps you to see it in writing all in one place, you probably want to access that little handout. We will practice a lot more blood gases in class so that we can answer everybody's questions. If you want additional practice, here is a website that you can go to. It's called ABG Ninja, and it just gives you, practice problem after practice problem, and you can practice until you feel confident. Because I guarantee you there'll be at least 2, maybe 3 blood gases that you'll be interpreting on the test. All right. If you have questions, go ahead and submit them so that I can answer them in class. I will see you then.